Let's go through the warm-up review. First question. A patient cannot adduct her left eye on lateral gaze, but convergence is normal. So which structure is damaged? Well, this is describing internuclear ophthalmoplegia. So the damaged structure would be the medial longitudinal fasciculus, specifically the left MLF in this case. Next, a 2-year-old child who's had multiple viral and fungal infections is found to be hypocalcemic. Which of the 3 germ layers gives rise to the structure that's missing in this child? So this is one of those 2-step questions. First, you have to recognize that this patient has DiGeorge syndrome. Then you have to know that DiGeorge syndrome is caused by failure of the pharyngeal pouches to develop, and that the pharyngeal pouches are derived from endoderm. So the answer here is endoderm. And the last one, describe the sensory innervation of the tongue. So the anterior 2/3 of the tongue are innervated by the facial nerve and the mandibular division of the trigeminal nerve. So the facial nerve is the taste sensation, and the other sensation is provided by the trigeminal nerve. And then the posterior third of the tongue is innervated by the glossopharyngeal nerve and the vagus nerve. The vagus nerve innervates the most posterior section of the tongue. All right, let's get started with the lecture.
Hello everyone and welcome to our Step 1 video on sympathetic activation. Now if you think this subject is about improving your ability to project sympathy or maybe kindness into an uncaring world, then you are out of luck. We will not be petting baby kittens, nor will there be any group hugs. The only hugs you'll likely see is you clutching your chest due to the severe tachycardia from a sudden increase in beta-1 activity caused by the sudden norepinephrine release due to the panic attack that you should be having right now because you don't know this material. Nah, I'm just kidding. This stuff's pretty easy. Look, a pretty kitty. Feel better now? All right, let's get going. So this lecture is going to cover sympathetic activation. In previous lectures, we covered parasympathetic activation and inhibition as well. So now we're going to cover the other side of the autonomic nervous system. Now recall when we spoke about the parasympathetic nervous system, we had a very long preganglionic neuron that ended at the ganglion very close to the effector organ. Acetylcholine would stimulate the nicotinic receptor at the ganglion, and then again acetylcholine would stimulate the muscarinic receptor on the effector organ. Well, this changes considerably in the sympathetic nervous system. The preganglionic neuron is very, very short this time, and the ganglion is going to be near the spinal cord, not close to the effector organ at all. Those postganglionic fibers are going to be very, very long, and they're going to branch multiple times, thereby innervating more than one organ system. Now again, the sympathetic nervous system uses acetylcholine to stimulate the nicotinic receptor on the ganglion, but then uses norepinephrine to stimulate adrenergic receptors on the effector organs. So why is this so important? Well, there can be tighter one neuron to one organ control in the parasympathetic nervous system. And again, that's due to those really long preganglionic fibers going all the way to the effector organs. You don't have that kind of control in the sympathetic nervous system. All those postganglionic fibers are branching all over the place. Therefore, when the sympathetic nervous system is stimulated, then you're really just tending to stimulate a lot of things all at once. So next, let's talk about the adrenergic receptors. This is the important part of this lecture. The 4 that you really need to know the most for step 1 are going to be alpha 1, alpha 2, beta 1, and beta 2. Now, when alpha 1 receptors are stimulated, this results in vascular smooth muscle contraction. So what is this going to do? Well, it's going to lead to increased peripheral resistance. It's going to give you some increased blood pressure. In the eye, it's going to act with mydriasis, and then also you're going to see some increased bladder sphincter muscle contraction. Next, let's talk about the alpha 2 receptors. Those are a bit different. You only find alpha 2 receptors on just actually a few organs, things like the beta cells of the pancreas and on certain smooth muscle cells. Now, the most important location of the alpha 2 receptor, though, is on the presynaptic nerve itself. And when stimulated, the alpha 2 receptor acts to inhibit norepinephrine release. So let's go through an example. So you have a sympathetic nerve fiber, and it's been stimulated to release norepinephrine. Some of that norepinephrine is going to circle back and then bind to the alpha 2 receptor on that same neuron. And what is it going to do? It's going to cause inhibition of further norepinephrine release. So this is actually a negative feedback mechanism. And then also because they're present on the pancreas, it kind of acts to inhibit insulin release. Next, we have the beta 1 receptors, and when they're stimulated, you're going to see things like tachycardia, increased lipolysis, increase myocardial contraction, and increase release of renin. And as you can tell, there's probably going to be a lot of beta-1 receptors on the heart. And then finally, we have the beta-2 receptor. So that's going to cause vasodilation, which will lead to maybe just a slight decrease in peripheral resistance. More importantly, it's going to cause bronchodilation. You're also going to see increased lipolysis, increased insulin release, and decreased uterine tone, another important one. You also generally see an increase in heart rate, but this is not because of direct stimulation of the heart like with our beta-1 receptors. Here, the heart rate is increasing because of a compensatory response due to that drop in blood pressure from that vasodilation. Now, adrenergically innervated organs tend to have a predominance of one type of receptor. For example, tissues such as the vasculature to skeletal muscle have both alpha-1 and beta-2 receptors, but the beta-2 are probably going to predominate. The heart, as we said before, contains a lot of beta-1 receptors, and then the lungs have a whole lot of beta-2 receptors. Okay, so let's pound this into your brain one more time. You have to know this stuff, Pat. Nothing else in this lecture is going to make sense unless we go through this again. So let's do another Lewis Notes. All right, welcome to another Lewis Notes, guys. We're doing another matching game. We're looking at our adrenergic receptors. We're going to combine our results here when we're stimulating these receptors. What are you going to get? So the first one we have here is heart rate, and we're increasing our heart rate, remember, with our beta-1. It's always going to be beta-1 because those are really on the heart. Next, we have decreasing uterine tone. Sometimes people forget this one, but this is actually going over here with beta-2. Next, we have increasing blood pressure. I'm putting this over here with alpha-1. It would probably also be with beta-1 as well, but alpha-1, you think of that peripheral resistance going up. Inhibiting norepinephrine, remember, this is very unique to alpha-2. That's actually how it's going to work to decrease blood pressure to some extent. Increasing heart contractility. So what's on the heart? Remember, on our heart is our beta-1s primarily. Mydriasis, this is another one that's a little bit trickier to remember, but remember, mydriasis is going to go with our alpha-1. Increased bladder sphincter tone, again, alpha-1. And remember, our alpha blockers are going to be going after those. Vasodilation. So vasodilation, it's not dramatic, but you are going to get a little vasodilation with beta-2. Increasing renin, that's going to go with beta-1. Bronchodilation, very important one, probably the most important one to remember is going to be with beta-2 again. And then increasing peripheral resistance, that's going to go along with our alpha-1 over here, and that's why you're going to increase the blood pressure with that. All right, guys, so that's going to be it for our Lewis Notes. So next, let's talk about the sympathomimetic. So a sympathomimetic is a drug that stimulates the sympathetic nervous system. However, the effect that each drug exerts is going to depend on which receptor it's going to stimulate. Now, since we just learned our receptors, we should be in good shape concerning these drugs. First, we'll cover the direct sympathomimetics. Now, the direct agonists or sympathomimetics bind to adrenergic receptors without interacting with the presynaptic neuron. That'll make more sense when we talk about the indirect. So the first drug we're going to talk about is epinephrine. So epinephrine stimulates all of the major adrenergic receptors that we just mentioned. So it's going to stimulate alpha-1, alpha-2, beta-1, and beta-2. Now, what are we going to use it for? Well, we'll use epinephrine for anaphylaxis. So if a patient is severely allergic to peanuts or bee stings, he or she may carry around an EpiPen, which is a syringe that a patient can carry around and then self-administer if they're having a big reaction. Now, it can be inhaled in certain respiratory problems like severe croup. Epi can also be used in hypotension. And that makes sense because the alpha-1 will vasoconstrict and the beta-1 will increase the heart rate. Next, we have norepinephrine. So here we see a strong alpha-1 and alpha-2 stimulation, also moderate beta-1 stimulation, and basically no beta-2. Now, norepinephrine can also be used for hypotension because it has such strong alpha-1 stimulation, it's going to decrease renal perfusion due to that vasoconstriction. Norepinephrine is usually first line for septic shock. And why would we want to do that? Well, in septic shock, you have a lot of vasodilation in blood vessels. But it can also be used for cardiogenic shock as well. Next, we have isoproterenol. This one only works on beta-1 and beta-2, and clinically, it's really not used that much, so I wouldn't put too much of your memory into that one. Next, we have dopamine. So dopamine is a weird one. At very low doses, dopamine will stimulate dopamine receptors. Now, we haven't talked about dopamine receptors yet. Now, most of the time, we think about dopamine receptors as being in the CNS, being associated with things like schizophrenia, Parkinson's disease. But we also have dopamine receptors in the blood vessels and in the kidney. Now, at medium doses, we see a change here. We see stimulation of beta-1 and beta-2. And at very high doses, you're actually going to start stimulating alpha-1 and alpha-2. So dopamine can be used in shock. It was thought that the stimulation of those dopamine receptors actually helped with renal perfusion, but studies now have shown that dopamine when used in shock actually doesn't improve renal function at all, so don't remember that one anymore for renal problems. Next, we have dobutamine. So this works primarily at beta-1 receptors. Now, dobutamine increases heart rate and that contractility. Now, you may see in some places that it won't increase heart rate, but it actually will. Now, we use this in stress tests. So some people actually have a hard time walking on a treadmill to get their heart rate up. So you can actually give them something like dobutamine, and that's going to stress their heart. You can also use this in heart failure as well. Next, we have phenylephrine. So phenylephrine causes strong alpha-1 stimulation. This is used for pupillary dilation, very commonly used as a nasal decongestant. Next, we're getting into some inhaled products. So albuterol, levalbuterol, salmeterol. So these have strong beta-2 stimulation, maybe just a little bit of beta-1 as well. So these are used mostly as inhaled drugs for asthma. Now, because of their beta-2 stimulation, they cause bronchodilation. That's exactly what you want. Now, because of that slight beta-1 activity, patients will often get some tachycardia, though this is less pronounced in levalbuterol. Next, we have terbutaline. This also has a strong beta-2, also has some beta-1 as well. Now, it can be used for bronchospasm, but you'll also see this being used as a tocolytic agent, so tocolysis. So that's going to hopefully inhibit uterine contractions in preterm labor. So there are beta-2 receptors on the uterus, which when stimulated will decrease uterine tone. Now, terbutaline can also be given sub-Q, which is great for very immediate action. And next we have a very interesting drug, clonidine. So clonidine is an alpha-2 agonist. Well, what happens if you only stimulate that alpha-2? So that's kind of our weird adrenergic receptor. Remember that alpha-2 is going to decrease the secretion of norepinephrine from the presynaptic neuron. So alpha-2 is that negative feedback mechanism receptor on that presynaptic neuron. So this medication can be used to decrease blood pressure. You have less norepinephrine around. So you have to be careful though with clonidine, because when you stop it abruptly, you can actually see significant rebound hypertension. All right, so now let's switch gears. We're going to move over to the indirect sympathomimetics. And now the indirect agonists cause catecholamine release from the presynaptic terminal, or their other mechanism is that they can inhibit the reuptake of catecholamine. So those catecholamines are going to stick around longer in the synaptic cleft. So these meds aren't interacting with the receptors on the effector organs like what we just saw with our direct agonists. They are just increasing the released norepinephrine and dopamine, and then those neurotransmitters will then bind to the receptors more, causing a lot more of the stimulation that we want to see. So what are examples of this? So the first ones are the amphetamines. So they work by releasing stored catecholamines. So you're getting more catecholamines out. So this can be a recreational drug. It's methamphetamines, it's speed. But in medicine, we can also use it for narcolepsy. You can also use it for obesity because it decreases appetite, and for attention deficit disorder. So again, remember that the amphetamines increase the release of the stored catecholamines, so you have more in that cleft. Next, we have ephedrine. Again, this is going to increase the released stored catecholamines, very commonly used in oral and nasal decongestants. It's also used in urinary incontinence as well. And finally, good old-fashioned cocaine. So this works a little bit differently. This is our second mechanism of action. So it's actually inhibiting the reuptake of the catecholamines. So the release is normal, but because there's less reuptake, there's more norepinephrine, more dopamine potentially in the synaptic cleft, and thus more stimulation of the adrenergic receptors. Now this does have some medical use. The ear, nose, and throat doctors will use this as a nasal decongestant and as a local anesthetic as well. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. So try to pause that video, try to answer the questions on your own, and then we'll answer them together. All right, first question. Which receptors are stimulated by the following sympathomimetics? So we're going to go through a big long list here again. So first we have clonidine. Remember that was our weird one? That's going to only go after your alpha-2 receptors. Next, we have dopamine. That's going to stimulate the D1 and D2 at very low doses. Remember, at that medium dose, you're going to get beta-1 and beta-2. And then at the high doses, you're going to get the alpha-1 and alpha-2. Next, we have phenylephrine. That's going to be doing a little bit more alpha-1 than alpha-2. And remember, that's that vasoconstricting drug. Next, we have albuterol. Albuterol is going to do a lot of beta-2 activity, but you're also going to get a little beta-1 as well. Norepinephrine, this is where it gets a little bit tricky, does alpha-1, alpha-2, and beta-1. It's basically just like epinephrine, except for you're probably dropping a little bit of the beta-2. Next, we have isoproterenol. That's going to be beta 1, beta 2 equally. Epinephrine is going to be alpha 1, alpha 2, beta 1, and beta 2. So it's doing the whole thing. Dobutamine is going to be beta 1 more than beta 2 and not very much alpha at all. And then terbutaline is going to be a lot of beta 2 and a little bit of beta 1 and none of the alphas. Next question. Which sympathomimetic matches the following statement? So first we have given as a nebulizer for asthma. So this is probably going to be albuterol or maybe levalbuterol. You could potentially put epinephrine here, but that's not first line. The first line med for acute asthma is going to be something like albuterol or levalbuterol. Next, we have drug of choice for anaphylaxis. That's going to be that EpiPen, so epinephrine is going to be the best for that. Next, we have most common first-line agent for patients in septic shock. So you think about norepinephrine is going to cause a lot of peripheral constriction. Next, we have given sub-Q for asthma, not done very often, by the way, but that's going to be terbutaline. Next, we have used as ENT to vasoconstrict nasal vessels. Could be either phenylephrine or occasionally you'll find a doctor who still has cocaine in their office and they can use it in that situation as well. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.